Okay, so this is a talk I usually give with Amanda Berger, who's a PhD psychologist over here at Metro Health and is the director of our behavioral sleep medicine program. And so I want to give her credit for a good number of these slides as well as content development. These are the objectives for today. We're going to go over some definitions, of course, about insomnia, discuss a little bit about what we know about the epidemiology and pathophys, look at some of the assessment tools that we use routinely, mostly on a clinical basis, although there are a number of research tools that are available as well. Look at some things around differential diagnosis, and then talk about treatment, both non-pharmacologic as well as pharmacologic treatment options. Basic outline here, starting with nosology, epidemiology, pathophys, talk about cognitive behavioral therapy and related behavioral therapies for insomnia. This talk is about 90 minutes, so we can maybe plan to take a 5 or 10-minute break around this point if people need it, and then we'll conclude with a brief review of pharmacology. Point of note, I mean, this really is meant to be a boot camp lecture. Each of these sections on its own could be an hour or two or more talk, and people devote careers to looking at these issues. So this is really designed to be kind of surface level overview, introductory kind of stuff. That said, if you have questions at any point, I'm certainly open to answering them on the fly. I'm not actively monitoring the chat, but if somebody wants to break in over audio and just let me know, that's fine. Okay, so definitions first. Recently, around the time that I was in the midst of my sleep medicine fellowship, the classification of insomnia changed. So as we transitioned from ICSD-2 over to ICSD-3 and from DSM-4R to DSM-5, there was a reworking, really a reimagining of our conceptualization of insomnia. And more than just nitty-gritty sort of criteria. This really was a complete working of clinically how we view insomnia. So we went from a very kind of fragmented and detail-oriented breakdown of primary versus secondary insomnia, including multiple subtypes of primary insomnia, to really just three insomnia diagnoses: chronic insomnia, short-term insomnia, and other insomnia. DSM-5 has a corollary of these, which is insomnia disorder, but the criteria that are used in both the ICSD and the DSM are essentially consistent. So for those of us who are dealing with that overlapping territory, it's fairly straightforward. But when we're thinking about insomnia, there are really three categories that we want to pay attention to. So first, there needs to be a persistent complaint of initiating or maintaining sleep. That's number one, associated with some kind of daytime symptomatology or impaired function. That's number two, despite an adequate opportunity to sleep. That's number three. And so that is the broad overarching framework for all the insomnia diagnoses that we're going to be talking about today. So um, as I mentioned previously, in ICSD-2 and DSM-4 TR, there were multiple different subtypes, primary insomnia versus secondary insomnia, and multiple subtypes of primary insomnia. And the current classification really was adopted because despite the fact that all of these subtypes of insomnia are interesting and in some cases clinically relevant, there really is not great differentiating validity between these subtypes. Patients can oscillate from one subtype to the next. There's not a great etiology and pathophysiologic sort of link between each of these. And even the primary versus secondary insomnia differentiation was often inaccurate. It's very, very difficult most of the time to determine the direction of causation. So that being said, you're still going to encounter these different subtypes of insomnia, either in old notes, old literature, old research, etc. And just because they're no longer in use diagnostically doesn't mean that they don't have some utility. So certainly as research on insomnia continues, people are looking at these different subtypes, and there's ongoing work looking at different phenotypes of insomnia. And so some of these may appear again later in one form or another once we have more data to support their existence and differentiation. But that said, again, what we're dealing with now in ICSD-3 and DSM-5 are three insomnia subtypes. And very simply, these are chronic insomnia, short-term insomnia, and kind of your garbage basket other insomnia. These are the ICSD-3 criteria. These are worth memorizing along with all the other ICSD-3 criteria. You are tested on this on the boards. Again, you've got these criteria A through F, all of which must be met. But again, these break down into those three basic categories that we discussed before. There needs to be a problem initiating or maintaining sleep. That problem needs to cause daytime symptoms or dysfunction, and that needs to happen despite an adequate opportunity for sleep. So, being on call is not insomnia. Being in an environment that doesn't allow you to go to sleep is not insomnia. Really needs to be an adequate opportunity to promote sleep. And then what makes it chronic insomnia disorder is that these things are happening at least 3 times a week for at least 3 months in duration. And that being said, many of the chronic insomniacs that you're going to see in clinic have experienced symptoms for years, decades, or more. So,
John, is the pediatric also incorporated in this with A45? Yeah.
It is. So one of the big changes is that the subtypes of insomnia we used to refer as behavioral insomnia of childhood are technically rolled into this diagnostic schema as well. That being said, you will very frequently see those old diagnoses used in pediatrics as well as in adult sleep also. Again, they can tell you something important about what the patient is experiencing, but from an official diagnostic standpoint, and certainly from an etiological standpoint, they're less distinct than we like to believe that they are. So we can differentiate chronic insomnia disorder from short-term insomnia simply by the duration of symptoms. And so here again, ICSD defines short-term insomnia as those 3 complaints we mentioned earlier: difficulty initiating or maintaining sleep, resulting in daytime symptoms or dysfunction or impairment, despite adequate opportunity to sleep, except there's no requirement for how often the symptoms are happening, and also that they have been occurring for less than 3 months. Importantly, both chronic and short-term insomnia contain this last little caveat here, which is that the difficulties and symptoms are not better explained by another sleep disorder. And of course, that's a big part of what we do when we're working up insomnia or really any other sleep complaint, is we're working on our differential and gaining better diagnostic clarity. Other insomnia disorder is not one that personally I've ever used, and my sense is that the crafters of the latest insomnia definitions in ICSD really intended this as kind of a transitional diagnosis when you either don't have enough history from the patient, or perhaps the timing hasn't quite worked out. So this is folks who are having sleep difficulties yet don't meet the criteria for one reason or another for either short-term or chronic insomnia. Again, this is not a diagnosis that I will typically use, but it is officially in the ICSD. There are lots and lots of daytime complaints that are classically associated with insomnia. None of these really differentiates insomnia from any other sleep disorder, and they include all of the things that you see here. So fatigue and malaise are very common. Mood disturbances of one sort or another are very common. Executive dysfunction, particularly poor concentration and memory, are very common, as are somatic complaints, as you can see here. Now, importantly, most people with insomnia, including chronic insomnia, are not sleepy. during the day, at least by objective measures. So they certainly complain of fatigue, they certainly complain of feeling tired and so on, but fairly consistently on any objective measure of sleepiness, they are no different really than folks without insomnia. They tend to be a lot less sleepy than folks with other sleep disorders, certainly less sleepy on average than people who have obstructive sleep apnea when you do objective testing. And oftentimes that's true subjectively as well. When you really drill down into the complaint, okay, you're telling me that you're fatigued, but if you have the opportunity to nap, would you? Oh no, I could never nap. So that's a common feature of insomnia and probably speaks to the pathophysiology, which we'll get into. As a general rule, if someone is coming to you with a complaint of insomnia and they're legitimately drowsy during the day, they're dozing, they're having difficulty maintaining alertness, there is very likely more than one thing going on here. They likely have overlapping sleep disorders. There are a number of consequences associated with insomnia, some of which we'll discuss later in this talk in detail. It's always a little bit difficult to quantify these things, but reliably, people with insomnia will report decreased quality of life. People with insomnia are more likely to utilize and overutilize the healthcare system. This results in more visits, increased healthcare costs. There are both direct and indirect costs in the workplace and on the economy at large, including both absenteeism as well as what we call presenteeism, which is showing up but being much less productive than you otherwise would be. There is probably an increased accident risk, although this is not seen to the same degree as motor vehicle accidents in untreated obstructive sleep apnea, for example. And some of the research in this realm is a little bit contradictory, but as we get finer and finer about defining our insomnia populations, some of the emerging trends do indeed suggest that the accident risk is elevated in insomniacs. And there are probably increased risks of certain medical problems and almost certainly increased risks of developing psychiatric symptoms and disorders. Now, we have to be careful with the wording here. There are very clear associations between psychiatric symptoms and disorders and insomnia, and there are fairly clear associations between medical problems and insomnia. But again, determining the direction of causation is very difficult here. Very likely the direction of causation is bidirectional, right? The arrow points in both directions. Again, it's hard to quantify these things, but when folks look at the costs to society of insomnia, we're talking tens of billions of dollars associated with lost productivity, absenteeism, presenteeism, overuse of medical care, etc. Okay. Insomnia is common. Insomnia symptoms are the most common sleep complaints in the industrialized world. They're very common in primary care. They're certainly common in our practice. Transient insomnia symptoms affect at least a third of people at one time or another. And we're talking lifetime prevalence here. Those are insomnia symptoms, but insomnia disorder, meaning insomnia symptoms combined with distress or daytime impairment, can affect up to 10% of people. Again, we're talking tens of millions of people. If you map out sleep insufficiency, now granted, this is not exclusively sleep insufficiency related to insomnia, but if you graph out sleep insufficiency, the prevalence in the United States looks like this. And if the map is familiar to you, well, it should be, because it overlaps with maps like this: death from heart disease in the United States, stroke death in the United States. And so, I'm showing you these only to imply that there are clear associations between poor sleep and poor health. And again, the arrow of causation very likely points in both directions. And this is certainly an active area of research at multiple levels. That being said, so despite the fact that insomnia is very common, despite the fact that it has real impacts on individual quality of life as well as some societal issues as well, most people who have insomnia do not end up discussing these symptoms with a physician. And so about 70% of folks in this is older data now, but I think this still holds true. About 70% of people never end up discussing these symptoms. With a physician. Of those that do, the majority discuss them at a visit that was set up for some other reason. And overall, only 5% of patients in this particular study ended up setting up a visit specifically to discuss their sleep complaints. Now, these are data from sort of general medical practice. This would look very different in a sleep clinic, obviously. But the point of this slide is that unless we ask, we meaning physicians, unless we ask about sleep complaints, we are very likely not going to hear about them. These are data that I really reinforce with our colleagues in primary care, but this is an important lesson for us as well. Even if patients may not be presenting to you with a primary complaint of insomnia, if we don't ask, we are likely going to miss some clinically relevant symptoms and opportunities for intervention. There are several major risk factors that have been identified in terms of the likelihood of developing insomnia. Insomnia is overrepresented in women compared to men. The prevalence of insomnia tends to increase with age. That's not 100% a reliable finding, and that association tends to diminish as you control for other things such as poor health and other medical comorbidities and so on. But in general, there is an increasing prevalence of insomnia with increasing age. Insomnia is overrepresented in people who have other medical problems, particularly certain medical problems, which we'll talk about. Insomnia is dramatically overrepresented in people who have certain psychiatric diagnoses. Particularly depression and anxiety. Depending on which study you look at, folks with depression and or anxiety, between 60 and 80% of those folks will report insomnia. Well over half, certainly. Insomnia symptoms are more frequently reported in people who have lower socioeconomic status. People who have a family history of insomnia are more likely to have insomnia. And the final common pathway here is purported to be hyperarousal. So folks who have habitual report of light sleep, folks who have certain physiologic measures, such as an imbalance between the sympathetic and parasympathetic nervous system, at least in research studies, are more likely to report insomnia, and when undergoing treatment are less likely to respond fully to treatment. Now, these are not things that we look at clinically very frequently, but the prevailing theory anyway is that the myriad factors, both personal and environmental, that increase our likelihood of having insomnia probably operate through this final common pathway of hyperarousal. I'm going to skip this slide. As I mentioned before, folks who have depression or anxiety are very, very likely to have insomnia. Again, between 60 and 80% of folks with those diagnoses report insomnia. It works the other way as well. People who have severe insomnia are much more likely to report psychiatric complaints. In fact, the odds ratio in people who have severe insomnia is 5 for having at least one psychiatric diagnosis, meaning not just having sort of some kind of psychiatric complaint or symptom, but actually meeting DSM criteria for a psychiatric diagnosis. One of the largest studies of tens of thousands of people in Europe showed fully 18% of that population had chronic insomnia. This was a relatively enriched population for medical complaints and so on. And of those people, nearly half had a current psychiatric disorder by, at the time it was DSM-4 criteria. And to make matters more complicated, medications that are used for psychiatric disorders can affect sleep both positively and negatively. And some of the medications used for sleep disorders can impact psychiatric symptoms. These may be somewhat difficult to read. I apologize for that. But what we're looking at here are two tables examining the prevalence of medical problems in people with insomnia. That's on the left. And on the right, we have prevalence of insomnia in people who have medical disorders. So sort of two ways of looking at a similar question. And for both comparisons, you see an adjusted odds ratio between about 2 and about 5. And so on the left, you can see that people with insomnia, about 86% of them reported having any medical problem, compared to a little bit less than half of people who did not have insomnia. And of these, the greatest difference was seen in chronic pain. Half of people with insomnia reported chronic pain versus under 20% of people without insomnia, and gastrointestinal complaints. Again, about a third of people with insomnia had GI complaints compared to less than 10% of people without insomnia. Flip it around. If we look at people who have chronic pain, about half of them report insomnia. People who have GI problems, a little over half of them report insomnia. So very clearly there are significant associations between medical disorders in general and insomnia, and certain diagnoses are certainly overrepresented in the insomnia population. This raises a lot of interesting questions. Certainly this research has not yet been fully worked out, but this is an area of active investigation. What are the common pathways between pain, insomnia, et cetera? Is it something simple like, simple sleep deprivation? Is it a bidirectional association, et cetera? I think this is an area of really interesting and fruitful research. I will tell you just parenthetically, many of the associations trying to look at direction of causation and, even basic research looking at prevalence have kind of been marred by issues of different definitions of insomnia. Historically, in fact, almost all of these studies are cross-sectional rather than prospective, et cetera. That's changing rapidly, and in the past 5 years or so, we've seen a lot of interesting emerging evidence, particularly on the health consequences of insomnia, which we'll touch on later in the talk. When we're talking about the development of insomnia, there are a number of conceptual models floating around out there, and although most of these are mostly academic, some of them actually have utility when we're trying to think about the development of insomnia, but also how we can intervene and design insomnia treatments. So I would say the dominant concept out there in the literature, and certainly the most important that I think we should be aware of, is Spielman's 3P model. Which you see here. And the basic concept here, for anybody who isn't familiar, is that we all have some insomnia threshold, some of which is genetic, some of which is environmental, deterministic, et cetera. But we all have a threshold above which we will have clinically significant insomnia, which is indicated here by the horizontal dashed line. And similarly, we all have some innate predisposition to insomnia. And for most of us, this should be well below the insomnia threshold. Again, whether this is the resting tone of our autonomic nervous system, our genetics, et cetera, we really don't know what that is. But we all have some set of predisposing factors. When an acute event or a precipitating event happens, that can create, shown in light blue here, precipitating factors, stress at work, a death in the family, having to give a talk about insomnia the next day, that sort of thing. Those factors on top of our predisposing factors tip us over the insomnia threshold. That's not a problem. That's not a disorder. That's human nature. The problem happens when, in response to the insomnia itself, we develop perpetuating factors. That's the third P shown in red here. Those perpetuating factors can persist even as the precipitating factors have declined. So as the acute exacerbation resolves, if we have developed over time these perpetuating factors, then that may cause persistent insomnia. That causes us to remain above the insomnia threshold. Very often, these perpetuating factors are developed in an attempt to combat the insomnia, which we'll talk about a little bit later on in the talk. Spending more time in bed, developing cognitive associations between being in bed and not being able to fall asleep, et cetera, et cetera. Say that again. Sorry, I missed that.
We're just muttering in here.
Okay.
You have two people together in a room and they mutter. I'll turn it off.
No, that's all right. Muttering is just fine. So this is important because these perpetuating factors shown in red are a target for one of our primary therapies for insomnia, which is cognitive and behavioral strategies. Now, this model over time has been sort of reworked and refined and made more complicated, but the 4P model is, I guess I would say, generally the accepted model, particularly in psychological research conceptions looking at insomnia. But you're seeing more or less the same thing here. The idea is the same, that we have predisposing factors, precipitating factors layer on top of that, perpetuating factors then develop, and on top of that we develop Pavlovian conditioning, the sort of classical conditioned response, which is often a target of stimulus control, right? So in cognitive behavioral therapy, you'll frequently hear this referred to as conditioned arousal. You know, I'm sleepy, I'm dragging my feet all evening, but the moment I get into bed, suddenly the lights in my mind switch on and I'm wide awake. Again, the perpetuating factors are what we target with CBTI. As those go away, the classical conditioning for maladaptive sleep is replaced with classical conditioning for adaptive sleep, and then we get a good treatment response. Okay, people seem to love complicated models and making diagrams of complicated models, looking at the underlying pathogenesis and etiology of insomnia. And I've shown just another couple here, only because they speak to the treatment strategies that we'll often employ in cognitive and behavioral therapies. But the idea here is there's cyclical reinforcement of insomnia. So we have the insomnia complaint, the difficulty falling asleep or maintaining sleep. That leads to cognitive and in some cases behavioral maladaptive issues. So we frustration, fear of sleeplessness, etc. That leads to physiologic activation, which leads to maladaptive attempts to combat the insomnia. These are the perpetuating factors leading to worsening insomnia symptoms, etc., etc. And so the whole thing snowballs. As I mentioned, the putative final common pathway is hyperarousal. And many different measurements of physiologic hyperarousal have been conducted over the years. Again, outcomes here have been fairly mixed. The findings are limited by all of the things that I mentioned before. We have heterogeneous definitions of insomnia. We have people at different points along their insomnia journey, et cetera, et cetera. But it is very likely anyway that the hyperarousal mechanism, meaning the sort of mistuning of the autonomic nervous system and the overexpression of sympathetic activity at the cost of parasympathetic activity, is responsible for developing and maintaining insomnia. There are lots and lots of different paradigms by which this can be examined. Some of the best, at least in my mind, are shown here. This is an older study now looking at plasma ACTH and cortisol in people who have insomnia versus people who don't. And the takeaway point here is that on average, the levels of secretion of these various substances are higher in people who have insomnia compared to controls. But in particular, there is an impairment in the nocturnal dip, the nocturnal nadir in these sympathomimetic hormones right up to and before the sleep time, as well as early on in the sleep cycle. This more recently has led to more robust associations between insomnia and health outcomes. As I mentioned, many of these studies are limited by a number of factors. They're cross-sectional, they rely on subjective measures of insomnia, they use different definitions of insomnia, and so we've seen variable outcomes with kind of poor reproducibility. However, in recent years, as more objective measures of insomnia have been employed, there is a fairly strong emerging signal for certain phenotypes of insomnia, and in particular, the high-risk phenotype appears to be insomnia with a short sleep time. And so what you're seeing here in the graph are people who have insomnia compared to people who don't. People with insomnia are shown in the dark bars. Normal sleepers are shown in the white bars. And these different groups are split up into their typical sleep duration. And this is PSG derived sleep duration over a number of consecutive nights. And you can see that the people who are routinely obtaining 6 or more hours, regardless of whether they report insomnia or not, are fairly similar in terms of their risk of developing hypertension. When we begin to segment that out, those who are obtaining only 5 or 6 hours of sleep on average over the nights of testing, that's when the differentiation really becomes apparent. Folks who have insomnia and are sleeping fewer than 6 hours have an odds ratio of 3.5 compared to normal sleepers. Those who are sleeping fewer than 5 hours have an odds ratio of over 5 compared to normal sleepers. So this is very interesting for a number of reasons. One, this shows that there's a dose-response relationship within insomniacs that is not present in people without insomnia, even if they're not obtaining adequate sleep. That's not entirely clear why that would happen, at least not to me. But again, one of the arguments is that folks who have insomnia are dealing with a different balance of sympathetic and parasympathetic tone that, when added to sleep deprivation, dramatically increases their risk. A similar relationship is seen between insomnia, sleep time, and diabetes. Again, insomniacs and non-insomniacs, if they're obtaining greater than 6 hours of sleep, have more or less identical risk for developing diabetes. People with insomnia sleeping 5 to 6 hours have about double the odds ratio. People with insomnia sleeping fewer than 5 hours per night have about 3 times the likelihood of developing diabetes. And very interestingly, there appears to be, at least for men who have insomnia and are not obtaining adequate sleep, there appears to be a mortality signal. So this same thing is not true for women. And that finding has been fairly reliably reproduced. But what you can see here is in men who have insomnia and who are routinely obtaining fewer than 6 hours of sleep a night, they have an odds ratio of about 4 for all-cause mortality. And now most of the studies looking at this kind of signal, and again, this has been reproduced once or twice in the 11 or 12 years since this was published, none of the studies are adequately powered to look at the etiology of mortality, and so most of these are going to look at all-cause mortality. So the sort of traditional teaching that your insomnia isn't going to kill you may not necessarily be true, at least for this severe insomnia phenotype with short sleep time. Okay, we're switching gears now, and I'm going to talk briefly about differential diagnosis, because this is an important part of what we do in the sleep center when we're seeing a patient who's referred to us with a complaint of insomnia. And sort of the top few differentials are shown here, and we'll spend a little bit of time delving into this. Much of this is going to be familiar to you even at this early point in your fellowship. But it is important to make this differentiation, because the treatments for so-called primary insomnia are going to be different from the treatments for some of these insomnia mimics. Certainly, we want to make sure that we're differentiating circadian disorders, particularly delayed and advanced sleep-wake phase disorders. We want to do a good history drilling into what the sleep environment is like. I can certainly share, in my own experience, and this has a lot to do with the population that we see over here at Metro Health. If you have the entire family sleeping on one mattress in the living room, because that's the only room in the apartment that has air conditioning, then that is not a sleep conducive environment, and that may not be insomnia per se. Certainly that causes insomnia symptoms, but that would not meet criteria for insomnia disorder. Doesn't necessarily mean you don't treat it like insomnia, but if you're trying to be accurate about the diagnosis, this is an important component of it. Insufficient sleep syndrome is, at this point anyway, probably the most common sleep disorder. But again, insomnia requires adequate opportunity for sleep. And so if somebody does not have the adequate opportunity, it's not insomnia. There's a massive overlap between comorbid sleep disorders, such as sleep disordered breathing, restless leg, etc., as well as comorbid other medical issues, pain causing sleep disruption, depression causing insomnia, etc. And lastly, medication and substance use, overuse, misuse, etc., can lead to insomnia complaints. I think everybody's going to be familiar with this, but one of the sort of straightforward ways to differentiate a circadian complaint from a primary insomnia complaint is to do a good sleep history, and the timing of their sleep difficulties, as well as the response of their sleep difficulties to an unrestricted sleep trial, can be very helpful in differentiating whether this is insomnia or a circadian complaint. Very simply, if you ask folks, if you have the opportunity to sleep without any social or schedule obligations, are you able to do so? And fairly frequently, people who have a circadian issue will reliably tell you, well, sure, if I, go to bed at 4 a.m. and I'm allowed to sleep in until noon, I feel fine, but I don't want to do that. And so in those cases, it's typical to see a long sleep latency along with evening alertness combined with significant sleepiness in the morning for delayed sleep-wake phase, and the opposite in advanced sleep-wake phase. Folks with advanced phase tend to be sleepy before their intended sleep time. They have difficulty maintaining alertness in the evening, but can often push through, particularly during that second wind time, but often have early morning awakenings. And so getting a sense simply through the sleep history of when their complaints are happening and how they respond to unrestricted sleep can help you reliably differentiate a circadian complaint from a primary insomnia complaint. I think we've talked about the sleep environment already. A general scheme for managing insomnia is shown here. much of this applies to the primary care and sort of pre-sleep clinic workflow. But as we're working with our colleagues and educating colleagues and designing workflows, I think it's important to keep things like this in mind. A good chunk of people with insomnia, at least short-term insomnia, are going to respond to basic education, sleep hygiene, etc. And a few sort of simple tweaks to their sleep routine, particularly when that is combined with good education about why we're doing that, can be very effective. Education and sleep hygiene on its own is insufficient for chronic insomnia. So for the purposes of patients that we're seeing in sleep clinic, education, sleep hygiene on its own is insufficient. But for the majority of insomniacs, again, we're not going to see those people in sleep clinic. For the majority of insomniacs, implementing a good sleep hygiene routine is perfectly sufficient. Um, there are both pharmacologic and non-pharmacologic strategies which can be used independently or in combination. In some institutions, including Metro Health, there's a direct referral pathway to cognitive behavioral therapy and brief behavioral therapy interventions before referring to the sleep clinic, or sometimes in lieu of referring to the sleep clinic. And from a systems perspective, as long as we're doing a good job screening patients and making sure that we're not missing other comorbid sleep disorders, this is able to identify and treat a large proportion of patients with insomnia, with a fraction of those eventually needing to be referred to sleep medicine. My argument would be this is the ideal way to do it, although the reality is many of these people end up getting referred to sleep medicine, and then we're the ones making the decision about whether to refer to behavioral therapy or not. But certainly there's evidence, both from the research as well as the real world, that a direct referral pathway from primary care to behavioral therapy can work and does work. Okay, we're going to talk a little bit about the assessment tools that are available to us in the sleep clinic for insomnia, and then we'll switch gears and conclude with talking about treatment options. The most important assessment tool in looking at somebody with insomnia is the patient history. There are a number of questionnaires available out there that have been validated. Most of these are used in kind of research applications. A few of them are used routinely in clinical practice, mostly to assess premorbid disease and response to therapy. But the most important tool that you have in your toolbox as a sleep medicine provider is the patient history. And this helps you not only figure out specifically what might be contributing to and perpetuating the patient's complaint of insomnia, but also that very important work of determining the differential diagnosis and assessing, ruling out, and evaluating other comorbid sleep disorders, medical problems, etc. Okay, the types of things that we look at, it may be obvious, but the major ones are shown here. Again, you're going to be interested in the onset, frequency, severity, duration, and characteristics of their insomnia complaint. It's not unusual that patients will give you sort of vague complaints to begin with, so it often requires a lot of drilling down into exactly what's going on. I will often ask patients to walk me through hour by hour what they're doing over the full 24 hours. Again, insomnia is not just limited to bedtime, but what we do during the daytime and prior to preparing to sleep all contribute to insomnia. It's important to assess their specific daytime impairment. What issues are they having? It's important to assess their risks and perpetuating and precipitating factors, what might have triggered this, and also what behaviors are perpetuating this. Obviously, a good medical, psychiatric, and neurologic history is important. Careful review of their medications and other substances is important as well. Occasionally, it's something simple. Stop having whiskey right before bed. Stop taking your anti-seizure medication right before bed, et cetera, et cetera. But it's often not that simple, but sometimes it is. Okay.
John,
Mhm.
John, I was just looking at your list that you had before and just thinking of one of my problems with the click that goes on with the EMR is it really doesn't put this together in an assessment of the patient. And you feel as though you have all the elements, but then you say it's insomnia in your plan or your assessment, and you really don't have this, you don't have these features. So this is a good slide to remember as you're making your assessment, that it has, that it is more than 3 months in duration, daytime impairment is this, sleep wake is this, I don't know about risk factors, but what would be potentially the Pavlovian features of a chronic insomnia, and then medications and habits. And that's really what you want to hear on as a professional sleep physician, not necessarily a box checker, right?
I think that's the major limitation. Yeah, exactly. The major limitation of doing this is time. If you've got 40 minutes or 30 minutes to evaluate your new patient, and they're coming to you with multiple complaints, many of which are vague, as they often do, it's very likely that you're not going to have enough time to adequately assess this. So, your practice may vary, but what I will often do is, we can reserve our first visit. For me, it's 40 minutes for a new patient. We can reserve our first visit to kind of identify maybe the top 2 or 3 complaints, design a plan for evaluating those better. But if it looks like there's a major insomnia complaint there, I may not get to all of these things. And then you say, okay, I think this is a problem for you. We need time to address this specifically. I want you to come back and see me in X amount of time, and we're going to spend that entire visit addressing this in detail. That's a bit of a luxury, I suppose. And if your next available visit is 4 months from now, maybe that's not the approach that you want to use. But there are lots of different ways that you could design that approach, particularly with telemedicine. Okay, I'm going to call you next week, and we're going to spend another 20 minutes going over your insomnia in detail. In the meantime, I want you to keep a sleep log, or in the meantime, I want you to delay your bedtime by an hour. That sort of a thing. So. It can certainly seem overwhelming to try and cover all of these things in one visit, and it is, and that's okay, and as long as we have a sense of where we're going and a plan for evaluating it comprehensively over 1, 2, 3, 4, 5 visits.
Yeah, we can talk about this later.
So, okay, there are a number, as I mentioned, of validated metrics looking at insomnia. Most commonly, you are going to encounter the Insomnia Severity Index, or ISI. This is a 7-question, maximum 28-point index looking at basically how big a problem are these different insomnia complaints for you, and to what degree are they affecting your life. Again, this harkens back to the diagnosis of insomnia. This is looking at your problems difficulty with your problems initiating or maintaining sleep, how much impairment is it causing you, and so on. And so very often when patients are engaged in therapy, particularly cognitive and behavioral therapies, we will administer this assessment to monitor their response to therapy over time. A good sleep-wake diary can be very helpful to supplement your sleep history, and certainly as you're administering therapy, this is a useful metric to obtain some objective data. It's a truism in all of medicine that we are poor historians of our day-to-day sort of habits and experiences, and so objectifying this through a sleep log is very helpful, not only to the patient but also to you as the practitioner as you're assessing response to therapy. The diary that I'll most often use for insomnia is the one here. This is the consensus sleep diary. This is free for clinical use and educational use. Um, and this is essentially asking you, the times that you got into bed, when did you fall asleep, how long did it take you to fall asleep, how many times did you wake up, et cetera, et cetera. This is useful because this allows you to build and calculate a sleep efficiency by, subtracting, box 1 from box 7. It gives you the time in bed. You can then calculate the total time asleep by, subtracting out the awakenings and the sleep latency and so on and so forth. And that gives you objective data to track and monitor over time. And many patients find this very, very helpful, even though they may not be noticing massive differences in terms of how they feel during the day. Simply the act of saying, look, your sleep efficiency has gone from 60% to 80% can be really motivating and is an important component of continued engagement in therapy. I think most of us are familiar, probably more familiar with this sleep diary here, with the 24 hours on the x-axis and the different days of the week over 2 weeks on the y-axis. This can be used for insomnia as well. Personally, I find it a little more difficult to calculate, the metrics that we most commonly use in insomnia using this diary. If I'm suspicious that there might be a circadian component to their complaint, if they're a poor historian and they give you an all over the map sort of sleep history, this can be helpful to sort of discern patterns. But if they're a reasonable historian and it's more of a garden variety type insomnia, I will usually use the consensus sleep diary. With any of these diaries, you want to be careful that you're not making things worse as opposed to making things better. And certainly people with insomnia can develop anxiety and perseveration specifically around completing these diaries, fastidiously. And so usually we'll say, it doesn't have to be perfect. Use your best recollection the morning after. Don't feel like you have to do these logs in the middle of the night. I don't really care about, 15-minute sort of time discrimination. I care about big picture type stuff. Okay. PSG is not routinely indicated for the evaluation of insomnia, asterisk, next slide. But it can be helpful, obviously, if you're suspicious that there might be another sleep disorder there, if the presentation is not clear-cut, if the initial diagnosis is uncertain, if they have a poor response to initial therapy, etc. Having said that, there's a very high prevalence of insomnia symptoms in people who have obstructive sleep apnea. And there's a high prevalence of an abnormal AHI, whether that meets criteria for OSA or not, in patients who have insomnia. So that being said, the right answer on the boards to what is your initial workup of a patient with insomnia is not PSG. In the real world, you're going to be conducting a comprehensive sleep history. And if you're suspicious that there might be another sleep disorder at work, then certainly a PSG may be helpful in evaluating that particular complaint or set of complaints. Similarly, actigraphy is not indicated for routine diagnosis or management of insomnia. But again, in certain scenarios, if you're suspicious of a circadian component, if, again, you're dealing with a patient who's a bit of a poor historian or they give you a sleep history that's all over the map, maybe a sleep diary is not going to be reliably completed, you can supplement that with actigraphy. Okay. being mindful of time here, I realize we've only got about 30 minutes, so this is going to be a little bit of a surface level kind of whirlwind tour through the treatment of insomnia. So there are both non-pharmacologic and pharmacologic treatment strategies for insomnia. These groups of treatments are strongly evidence-based and very consistently have been shown to be highly efficacious and, for the most part, highly effective. Um, the best studied and most commonly implemented non-pharmacologic technique is cognitive behavioral therapy for insomnia, known as CBTI, and the component techniques of CBTI are listed here. So we will frequently do education around sleep hygiene, again, promoting habits that help rather than hinder sleep, but most importantly, we're providing education around the rationale for doing what we're doing. So sleep hygiene on its own has been shown to be insufficient for the treatment of chronic insomnia, but as a component of CBTI, it's really important, in my experience, to tell patients why you're doing what you're doing, to get their buy-in, and to promote ongoing engagement with therapy. When we talk about stimulus control, we're talking about essentially impacting the Pavlovian response, or the classical conditioned response of being in the sleep environment and being unable to sleep. You want to replace that association with a positive association, being in bed and being able to fall asleep. Sleep restriction is an important component aimed at optimizing your sleep efficiency. You'll remember back from earlier lectures in this year when you learned about process C and process S. Sleep restriction is harnessing process S, the homeostatic sleep drive, to optimize sleep pressure in the treatment of insomnia. Relaxation training targets that hyperarousal final common pathway to reduce arousal, decrease anxiety, etc. And cognitive therapy can be used to address the sort of maladaptive thoughts and beliefs that feed into perpetuating insomnia. Okay. Tenets of stimulus control. We should use the bed for sleep and sex only. We want to make sure that our patients are going to bed only when sleepy. Again, we want to build up an association between being in bed and being sleepy or falling asleep, not being in bed and being anxious, or being in bed and being unable to fall asleep. What that means is that if somebody is in bed and they're not able to fall asleep within a reasonable period of time, and usually we say about 20 to 30 minutes, we ask folks to get out of bed to break the association and avoid reinforcing a negative association between being in bed and being unable to fall asleep. Similarly, we're talking about waking up at a consistent time, maintaining a consistent sleep schedule on work days and days off, school days and weekends, etc. And we're avoiding daytime naps as part of optimizing sleep pressure. Sleep restriction is among the most powerful components of cognitive behavioral therapy. Typically, the way I'll administer this, and I think this is consistent for most people, is that I'll ask patients to do a baseline sleep diary to determine their average time in bed and their average time asleep. And then I'll design the therapy setting their time in bed to equal their time asleep. We want to schedule a consistent wake-up time. We want to discourage daytime naps. And then as you're following therapy, you're asking patients to keep a sleep log. You're tracking their sleep efficiency. If they have a sleep efficiency of 85% or greater, then I will usually extend their time in bed by 15 to 20 minutes. You can probably be a little bit more liberal here, maybe 30 minutes. But if their sleep efficiency is under 80%, you can further restrict their time in bed. The idea being you want to crunch sleep time to as short as you can safely and comfortably get it, and gradually extend back out to the desired sleep time. Important caveat here, I think there's pretty good evidence that you really never want to go under 5 hours in bed, or targeting a total sleep time of 5 hours. And for folks who have certain psychiatric conditions, particularly bipolar disorder, you are probably not going to sleep restrict any more than about 6 hours due to the risk of exacerbating mania. Okay, relaxation techniques can be very helpful in CBTI. These involve things like progressive muscle relaxation, diaphragmatic breathing, meditation, guided imagery, biofeedback, mindfulness, etc. There's no evidence that any one of these techniques is superior to another, and so typically I'll offer a menu of these to the patient, throw a bunch of these at them and see what sticks. I'm a big fan of diaphragmatic breathing or square breathing, simply because it's easy to learn. It can be practiced anywhere, and it's useful for more than just insomnia. But again, you're going to be designing an approach that specifically works for your patient. And then cognitive therapy focuses on restructuring the cognitive misattributions that come along with insomnia. So very commonly, there's catastrophic thinking, there's learned helplessness and hopelessness. I've got a big meeting tomorrow. I really absolutely have to sleep. If I don't, my day is going to be terrible. Everybody's going to know that I haven't slept, and everybody's going to think I'm an idiot, and my day is going to go horribly, and I'm going to get fired from work. And so this is an example of catastrophic thinking that can perpetuate the anxiety and conditioned arousal that happens with insomnia. And so there are techniques to identify these cognitive misattributions, to challenge them, and to provide alternatives. I've been sleepy before. My day went fine. Nobody remarked that I was tired. I made it through my day without any problems, and I haven't lost my job. That sort of a thing. Okay. All righty. Because we're short on time, I'm just going to gloss over these. CBTI is effective. There are a number of meta-analyses now showing very strong effect sizes for a number of subjective and objective measures of sleep duration and quality. Big picture, CBTI is effective in about 60% of cases. There are lots of various iterations and variations of cognitive behavioral therapy. It can be performed in a group, and there's evidence supporting all of these various iterations. Group CBTI can work. Self-help CBTI, internet CBTI can help. Computer-based CBTI is an option. And so when you are referring patients for therapy, and when you are in your own sleep practice, designing a sleep practice, working on your referral patterns, etc., it's important to realize that there's more than one way to do this. So you don't necessarily have to have 2 or 3 behavioral sleep medicine experts on staff. Psychologists are expensive. Your time is expensive. There are ways to design these treatment protocols that aren't quite as resource intensive, but can be equally effective. So that's a topic for a whole other talk, but more on that later. Okay, pharmacotherapy. So as with any other treatment for insomnia, you really want to meet the patients where they're at. It's important to individualize the treatment to the patient, and therefore it's important to understand the mechanism of action of the medications that you have at your disposal. It's important to understand how quickly they act, their duration of action, their half-life, their interactions, et cetera, when you're trying to optimally treat patients for their insomnia. For example, if someone is complaining of middle of the night awakenings but have no no difficulty with sleep initiation, using an ultra short acting sleep medication at bedtime is probably not your best choice. Similarly, if somebody is complaining of sleep onset insomnia, but once they're asleep, they stay asleep, using a very long acting soporific agent that's more likely to cause hangover effect in the morning is probably not your best choice. So again, you want to understand the pharmacokinetics and pharmacodynamics, and then compare those and match those up to the patient's actual complaint. I'm going to skip through this. Okay, so this is important. In 2017, American Academy of Sleep Medicine published their guideline for pharmacologic treatment of chronic insomnia in adults. This is often surprising to people when they see the types of medications that are recommended and the types of medications that are not recommended compared to the real life practice. Important point of note here, the way these sorts of studies are conducted and these guidelines are prepared is that they rely on quality of evidence. And if the studies with high quality evidence don't exist, then they're not able to provide a strong recommendation and may end up providing a recommendation against. We'll come back to this slide in a second, but just remember, no evidence for something is very different than evidence against something. And this is an important thing to keep in mind as we're considering the real world applications here. When I show this slide to primary care docs, particularly our primary care residents, one of the very common elements of feedback is, if we look at the top few medications that are recommended, this one's a controlled substance, this is a controlled substance, this one, this one, this one, this one. Those are all controlled substances. Ramelteon is not, doxepin is not. So of the 8 recommended medications, 6 of them are controlled substances. And certainly, you will be very familiar and comfortable prescribing these in the sleep clinic. But certainly our residents at Metro Health, and I imagine many other places, give us the feedback regularly that they're actively discouraged from providing controlled substances. And so this potentially is a big issue. That's not necessarily the wrong way to approach it. These things are controlled for a reason, but you will very often see that patients referred to you from primary care are on medications that are not on the recommended list here. Similarly, if we look at 9 and below, AASM is recommending not to use trazodone, not to use Benadryl, not to use melatonin, asterisk, except in certain populations. And so it's important to bear this in mind as we're designing a treatment strategy. Okay, the reality is that, again, you want to meet the patient where they're at. You want to consider what has been tried, the degree of success or lack thereof of different types of medications, the mechanism of action, and whether you want to consider a novel agent, et cetera, et cetera. I can tell you my own practice, regularly uses things like trazodone, things like melatonin, et cetera, in certain populations and in certain contexts, as long as there's a good reason in the patient history for doing so. Okay, this is probably a good slide to memorize, for your practice as well as for the purposes of the boards. What we're looking at here are benzodiazepines and non-benzo benzodiazepine receptor agonists, the so-called Z drugs. The important thing here to be aware of is that these various medications have different times to onset. Most of them are in the 10 to 25 minute range, but some of them, temazepam, for example, takes a good bit longer, up to an hour. And the elimination half-life of these medications is very different. Again, elimination half-life doesn't necessarily mean the effective half-life, but again, if you're dealing with some of these benzodiazepines, again, temazepam, this is going to be in the system for the majority of the day and is much more likely to result in, morning residual symptoms as opposed to a very quickly metabolized medication like Zaloplan. Okay. Okay, I think everybody's familiar with the mechanism of action of benzodiazepines. So they bind to a receptor subunit. They potentiate GABA binding to other subunits on the receptor, and that potentiates intracellular movement of chloride, which hyperpolarizes the cell and results in inhibition, reduced firing. There are a number of effects of benzodiazepine receptor agonists on sleep: improved sleep continuity, decreased sleep latency, decreased number of awakenings, and increased sleep durations. Benzos per se are known to decrease N3 sleep. This is not necessarily true for the non-benzo BZRAs. Benzos per se tend to reduce REM sleep. Again, not true for the non-benzo agonists. They result frequently in characteristic EEG findings, increased duration and number of sleep spindles. You'll often hear this referred to as excess beta. And they may also have a beneficial effect on reducing periodic limb movements and PLM-associated arousals. The weighted effect sizes on these various objective sleep metrics are shown here. These are sort of pooled data for benzoreceptor agonists, although most of this is referring to zolpidem. As a reminder, an effect size below 0.5 is considered kind of small. Between 0.6 and 0.7 is average, and above 0.8 is large. So most of these metrics have at least a moderate effect size in response to benzo agonists. When we look at the most commonly used medications in our practice, these certainly are effective, not just in the short term, but also over the long term. There are data looking at zolpidem usage 12 months out, and that's demonstrated good efficacy and safety. This particular slide here is looking at Lunesta, esapicolone, compared to placebo over 6 months. And so the point being, you've got a real, significant, and durable benefit on multiple metrics of sleep quality. So improvements in sleep latency by about 20-ish minutes, reduction in wake after sleep onset by about 20 minutes, and an increase in total sleep time by about 50 to 55 minutes that's associated with esapicolone. There is the potential for rebound when discontinued, but what this slide is showing you is that intermittent usage is probably as effective as every night usage in the benzoreceptor agonists. It's a little bit hard to read, but A and B, the green and the blue, are zolpidem. So these are patients in the group that was prescribed Ambien. The nights that they were taking it, and this is total sleep time, the nights that they were taking it are shown in green. The nights that they weren't taking it are shown in blue on the bottom, that's B. And then C and D are the placebo group, so they're prescribed a placebo. The nights that they took it, you have the red bar. The nights that they didn't take it, you have the yellow bar. So a couple of points here. One, the placebo effect is real. Patients slept less on the nights when they didn't take the placebo compared to when they did. That's number one. Number two, there is probably a rebound effect if you're prescribed zolpidem. Certainly you sleep better on the nights when you take it, but on the nights when you don't, you're sleeping less than folks who were in the placebo group. But also when you resume taking it, you still get the sustained benefits. Okay, use and abuse. People worry a lot about this. It is a real concern, but it's probably not as significant as maybe we make it out to be. Most people who are prescribed, these are benzodiazepines in general, not just soporific benzos, but 70% of people who are prescribed benzos use them for fewer than 2 weeks, as long as it's prescribed for a sleep-related purpose. Fewer than 5% escalate the dose, and people who do escalate titrate the dose are almost exclusively people who have a history of other substance use and abuse disorders, particularly alcohol use disorder. Actual abuse, again, is almost exclusively seen in polydrug abusers. And in the Z drugs, reinforcing properties are relatively low. Certainly they can be habit forming, but much less magnitude of concern than we often make it out to be. I imagine everybody's familiar with this. There are a number of possible side effects from the Z drugs. Daytime sedation, particularly if it has a longer elimination half-life. Cognitive and motor impairment, although that is related to the plasma concentration. So immediately after taking the medication, that impairment is very likely. As the medication is metabolized, that becomes less and less problematic. Anterograde amnesia is a possibility, more so with the actual benzos as opposed to the Z drugs. Again, rebound insomnia, parasomnias are a real concern, and these tend to be, highly publicized and talked about, and they're certainly real, but the actual incidence of this is quite low. And again, there is an effect, opportunity for these medications to be habit forming, but again, as we talked about, the actual rates of abuse are quite low. Very quickly, some specifics about zolpidem, because it's among the most commonly used medications that we prescribe for insomnia. It's got evidence supporting both short-term and long-term usage. Again, there's data looking at 12 months of continuous every night usage. There are various formulations available. The kind of standard tartrate, which is an immediate release oral tablet. There's the continuous release formulation. There's an oral spray. There are sublingual lozenges and sublingual tablets that are approved for middle of the night usage and early morning awakenings because of rapid metabolism and short elimination half-life. Again, the two conditions in which you would consider using these: at bedtime, your standard zolpidem and zolpidem CR, versus middle of the night administration for your spray or sublingual tablet. Again, evidence here supports longer total sleep time, fewer awakenings, shorter sleep latency, better subjective sense of falling asleep, better subjective quality of sleep, and increased sleep efficiency, both on patient-reported metrics as well as on PSG. Okay. Good safety profile. You want to avoid this in pregnancy. Again, we talked about complex sleep-related nocturnal behaviors, parasomnias, that kind of a thing. And again, next day hangover effects. Okay. All right. Melatonin. I'm just very briefly gonna touch on this again. The official party line is that in the general population, the evidence does not support routine usage of melatonin for chronic insomnia. That being said, in certain populations, there is probably a use case. This is true in the elderly who have declining melatonin production. Their melatonin amplitude is lower. Children, specifically those who have ADHD or autism. Kids with autism not infrequently are melatonin deficient. Patients taking beta blockers. So beta blockers can result in decreased melatonin secretion. So they may benefit from a melatonin supplement. Obviously, people who have circadian rhythm disorders might benefit from melatonin. And in patients who have comorbid sleep disordered breathing, at least if it's untreated, if you're looking for medication or a supplement that's not going to impact their respiratory drive, melatonin may be a good option. There is a recommendation supporting the usage of Ramelteon, which is a melatonin receptor agonist in chronic insomnia. And again, Ramelteon does not adversely impact the AHI or the oxygen indices in mild to moderate apnea. There are newer medications with novel mechanisms of action. These are the orexin receptor antagonists. Just about all of these are dual orexin receptor antagonists with varying degrees of affinity for orexin 1 and 2. Suvorexant and lemborexant were the first two available in the United States. Quvivic or daridorexant is available now. Quvivic is the the only one that's available in Europe at the moment. Suvorexant and lemborexant are not approved yet by the European Drug Agency. Half-life for these varies between 8 and 12 hours. Daridorexant is a little slower, a little lower, close to 8 hours. Suvorexant and lemborexant are at the more 12-hour range. And the dosing of these is shown here. As with anything else, you start at a low dose and you escalate based on the clinical response. All of these are metabolized by cytochrome P450, specifically the 3A4 enzyme. And so you want to be careful with medications that inhibit 3A4 and consider a concomitant dose reduction. We don't need to review that. Although there's only one antidepressant that has a recommendation for insomnia by the FDA, and incidentally, that also has a recommendation by the American Academy of Sleep Medicine for insomnia, and that's low-dose doxepin. You'll see a number of other antidepressant agents that are used for insomnia. Trazodone, far and away, is the most common. Mirtazapine or Remeron is the other. Both mirtazapine and doxepin have the interesting characteristic of being more effective as a soporific agent at low doses compared to high doses. And so as you escalate the dose towards an antidepressant dose, you get more adrenergic effect and less benefit on insomnia. I think we can skip this. I think we can skip antihistamines. 10 seconds on herbal therapies. We're 10 randomized control trials in and counting, and all of these have failed to demonstrate any benefit of these supplements here over placebo. That being said, placebo effect is real, and so if you're on a relatively benign supplement, then so be it. Okay. I think we're going to wrap up, just being close to the end here. Big picture, very briefly, there is evidence that combining behavioral and pharmacologic strategies is effective, and probably more effective than pharmacologic treatment alone for insomnia. It's important to meet patients where they're at, whether we're talking about cognitive, behavioral, or pharmacologic therapies, and to design a treatment regimen that addresses the symptoms that they're actually experiencing and the other medical and non-medical comorbidities that are present. As with anything, you want to use the lowest effective dose for the shortest period of time, but there is evidence supporting long-term usage of many of these medications. That said, many of the patients who are coming to you in sleep clinic have had insomnia for years, if not decades. They will have tried many of these medications before with varying degrees of success for varying amounts of time. And so the types of patients that we see in the sleep clinic are relatively skewed towards the right side of the curve, meaning relatively more likely to require longer-term usage of medication, probably likely to require higher doses of medication, and more likely to require combination therapy. All right, so that was very much a whirlwind tour. Thanks everybody for not falling asleep, at least those of you that I can see on the video. And maybe in the remaining couple of minutes, I'd be happy to answer questions if